Hello, everybody. Thank you so much for coming and listening to us today. We have an exciting topic to talk about. We're going to be talking about venous origin, chronic pelvic pain, and potentially lower extremity venous origin pain. Really excited to talk about this. My name's Ron Winokur. I'm an interventional radiologist. I'm in New York City at Weill Cornell, specializing in varicose veins, deep vein thrombosis, iliac obstruction, as well as venous origin pelvic pain, and interested in the topic of ovarian vein embolization and understanding the sources of venous origin pelvic pain. And we have a partner here with us who's going to be speaking as well.
Hello, everyone, and thanks for the invitation. It's really a pleasure for me to be here with you. My name is Alexandra Jaworucka-Kaczorowska. I am from Poland. I am both a specialist surgeon and obstetrics and gynecologist. I work in Poland in Gorzów in the private clinic. I'm doing all type of veins and especially pelvic venous disorders.
All right. This is going to be a fun discussion. So we're going to frame this and go through a couple of case presentations and discuss back and forth kind of how we think about these cases and how we plan to manage this challenging population of pelvic venous disorders. So I'm going to start with a case presentation. So a little bit of a difficult decision making as far as iliac vein obstruction or ovarian vein reflux. What do you manage? How do you manage it? Which one do you manage first? So here's the potential case. So this is a 42-year-old woman, pelvic pain for 12 years, started with her second pregnancy, and then worsened with each pregnancy after that. And she had 5 pregnancies. So pretty severe pelvic pain. She's had hysteroscopy, and you can see images from the hysteroscopy here. And the biggest piece that's being shown here, you can see large varices on those hysteroscopic images. And then there's a transabdominal ultrasound image of the pelvis with the uterus at the center, and you can see large varices on both sides as well. Going through her history, she describes her pain as bloating, heaviness, and aching deep within the pelvis, so in the deep side of her lower pelvis. And she rates it, if we do a VAS pain score, she rates this as 2 to 3 out of 10 daily, 5 out of 10 with standing, 8 to 9 out of 10 after intercourse, exercise, and prolonged standing. So I don't know about for me, but this is, typical symptoms that I see in patients who have venous origin pelvic pain and pelvic venous disorders. Looking a little more at some imaging, here's transvaginal ultrasound images. You can see on color Doppler on the first image, there are large varices there. On the second image, you can see in the left ovarian space, you can see some pretty large varices there as well. And then this patient before coming to see me, had a CAT scan as well. And so you can see CAT scan images here. And I want to point out a couple of things. There's contrast in the aorta. There's no contrast in the IVC. Here's the left ovarian vein with contrast, so demonstrating reflux in a dilated left ovarian vein. Central left common iliac vein sitting under the right common iliac artery appears to be compressed. And then central left renal vein between the SMA and the aorta, again, appears to be compressed, and maybe the peripheral renal artery is a little bit dilated. So here's the challenging situation that we face. Some images of her pelvis, and you can see as well that there are large varices as seen on all of the ultrasound images. There are left periuterine, periovarian varices. So the question I want to bring up first is this venous origin pelvic pain? What do you think?
It may be. I'm not sure about that, definitely. But of course, it may be. But of course, we have to also remember about any other comorbidities which may cause the pain. You showed that she had, probably it wasn't hysteroscopy, probably it was laparoscopy before, because the view from which you showed on the photo, which was laparoscopy, I had to say that as a gynecologist, sorry.
That's fair.
But of course, we have to remember about other causes which are even more often than the gynecological causes. That's irritable bowel syndrome. Of course, she said that she had some bloating. Of course, we have to also remember about myofascial pelvic pain syndrome and other causes which may be also a comorbidity and may cause pain. As you know, as a gynecologist, I see many patients with a huge varicosities and they do not cause pain. So definitely, we cannot be perfectly sure that this is the cause of her problem. But of course, probably it is, and I will do something about that for sure.
Yeah, I think it's always hard to make the choice many of these patients, at least by the time they see me as an interventional radiologist, they've been worked up by a gynecologist before. They've undergone pelvic floor physical therapy. They've attempted hysteroscopy, laparoscopy, and attempted other interventions to try to treat their pain. And by the time they're coming for intervention, they've already been worked up and ruled everything else out. And that's the best case. When patients...
Yeah, that is very important. That just to rule out all other causes which may be the reason of pelvic pain, and not only just start embolization if you see only the varicose veins, because you have to remember that very often other causes make the symptoms. And I would like to ask you, because it was very interesting that you said that the patient very often has laparoscopy. I saw many cases on the conferences, and you always say that the patient is after a laparoscopy. In Poland, it's not the standard procedure that the patient with the pain has always laparoscopy. It's we have to remember that it's very invasive diagnostic. You can do other, for example, you can do MRI with a protocol for endometriosis. You don't have to do laparoscopy. So is it a standard procedure that in the US you are doing laparoscopy to all patients with the chronic pelvic pain?
I think it's hard because I see them so secondarily or further down the line when they've been worked up by gynecologists. Our gynecologists in the US seem to favor doing laparoscopy first. Often they will have an MRI beforehand. They'll have CAT scans beforehand, which is why in this case you've seen all of that imaging as well. They've had transvaginal ultrasounds.
Yeah, but on CT scans, the endometriosis is not so well. Definitely MRI.
Exactly.
Yeah, it's better to see. That's why in Poland we do not do that often the laparoscopy. We just do another images, and if you don't see endometriosis in MRI, you do also this blood test. You are looking for CA 125, and if it's not higher. And on MRI, if you don't see endometriosis, we probably wouldn't do laparoscopy as a first treatment diagnostic tool.
Yeah, I think that's a great point to make and important in the workup of these patients. And so you can see here's the next question that I was going to discuss, which is kind of what we've already been talking about. So how do we work these patients up for chronic pelvic pain, and kind of deciding what kind of imaging is going to push us to think that the origin might be venous and might be pelvic venous disorders. And, I think that this was really helpful. Transabdominal ultrasound, MR venography, I think is really useful. Transvaginal ultrasounds can identify these varicosities as well. So it seems like, all of this imaging is necessary. Maybe laparoscopy is not necessary.
Yeah, I think that definitely we should start from, maybe not from CT scan as it was in this situation, but definitely from transabdominal ultrasonography. I always do both transabdominal and transvaginal ultrasonography as a gynecologist. It's easy for me. And if I see something which maybe I see varicosities, or I think that maybe it is the venous problem, I always do MR venography. We usually do not do CT scans, but MR venography.
And I think one of the advantages is, and here's some images of transabdominal ultrasound. I like it because I can visualize all of the vessels and ask the question, is this iliac vein obstruction, ovarian vein reflux, renal vein obstruction, and really understand the anatomy and the flow patterns. And so here's some images from that particular imaging assessment. You can see a central image here of the left common iliac vein. The left common iliac vein looks small and it looks compressed. But there's antegrade flow in the blue color here in the left internal iliac vein.
And I have also a question about the examination you performed. Was the patient lying, or is it the bed with a 35 degree? Because it's very important when you are diagnostic this compression syndromes. And also, do you put the patient on site just if you see, for example, this compression, just to realize that it's compression or it's not?
I do both, and it's a great question. It's technically challenging. I have the advantage of doing a lot of these ultrasounds myself in the office, and so I'm starting, and I will have them supine, usually like a 30-degree angle on the bed, so their head of bed is a little bit up, to try to create a little more dilation of these veins so that they're not completely flattened out and emptied out. And then if I do see this type of compression, I will decube them and scan more in the decubitus position to see if that'll change and resolve the compression as well. It's a great question. So I guess that answers the question here. Is this iliac compression, and is this significant in kind of what we're looking at here? To me, it's not. Yes, there's a compression here. Yes, that central left common iliac vein is much narrower under the aorta, but there's antegrade flow in the internal iliac vein. So I kind of was, we could probably discard that as significant compression, and I usually leave iliac vein stenting as secondary anyway. Here are some images of the left ovarian vein dilated. You do too, right?
Yeah, no, I do the same like you. I do not do stenting as a first treatment. And definitely for me, it wasn't a significant compression because of the flow in the internal iliac vein. So I agree with you.
Perfect. So here's the left ovarian vein. It's 5.7 millimeters, which is kind of at the top end of normal. Maybe bigger than 6 would make me a little more suspicious that this is abnormal. We definitely see higher rates of reflux over 6, but it looks like there's retrograde flow by color Doppler here. So there's, the red is retrograde flow in that left ovarian.
I have a question to you because, for me, it's very difficult to record the reflux when you are doing ultrasonography. Because when you are doing the Valsalva maneuver, everything is moving, the belly is moving, the patient is moving, and it always disappears. So do you have any tips and tricks how to record it?
So I will watch in long axis like this with color on, and then I do augmentation. So I press on the lower abdomen in the left lower quadrant and observe. And I try to have the patient stay and remain very still when I'm doing that augmentation. Sometimes it causes pain. These patients have pelvic pain and I'm pressing on their pelvis, so sometimes there is pain. But that creates a lot of that retrograde flow. It's almost like augmentation in the leg when you're dealing with lower extremity varicosities. You can augment and then see retrograde flow and reflux.
I now bought a pedal just to press the pedal leg by leg to record it, because otherwise you keep prop in one hand, press the belly in the other hand, and you don't know how to press the record. But it's... Yeah.
Yes, I agree.
Yeah, so definitely I will do ovarian vein embolization first.
Yes, I would also. I would start here with ovarian vein embolization. Even though that left common iliac vein looked a little tight on the images, at least that I showed, if it resolved with oblique positioning, great. The antegrade flow in the internal iliac vein makes me think that we could start with the ovarian vein. Yeah. So here's some images from angiography. So here I do mine from an IJ approach. So here we got into the right internal jugular vein, got into the left ovarian vein. You can see dilated left ovarian vein with reflux into a large pelvic reservoir. Seems to be staying fairly stagnant within that pelvic reservoir and filling all the periuterine, periovarian varices. I use an occlusion balloon there. So I have an occlusion balloon in and then inject sclerostin into the pelvic reservoir to treat that pelvic reservoir. I think that's an important component of this therapy, that we treat the pelvic reservoir and get rid of the varices.
I have also a question. Have you checked also the other vein? So the tributary, the other side of, the right ovarian vein, and because you didn't show it, and the branches of the internal iliac vein, do you check it?
Not yet. So usually, because there was so much pre-procedure imaging with ultrasound and everything else, I'll usually know that I'm going to treat the left ovarian vein first. So I'll start with the left ovarian vein and then attempt to do the right ovarian vein. About 20% of the time, I can't get into the right ovarian vein, so I'll skip that and then get into the internal iliac veins and check both internal iliac veins for any remnant varices.
So you do this? You do this always?
I do this always. All 4 vessels, always. Yeah. And I think that's important. There's research coming that we're all trying to prove that you should be being very strategic in evaluating all of the vessels. At a minimum, probably should be treating bilateral ovarian veins and possibly treating the internal iliacs every time as well.
I have also a question, because you did an embolization with the coil, and of course you did the sclerotherapy. Do you use foam or liquid sclerotherapy, and what percentage?
Yeah, I mix my sclerostin. I use Sotradecol 3% and mix it with contrast and gel foam. So I make a little bit of gel foam slurry to make it a thick slurry to go down there. What do you use?
Yeah, we use foam, usually polydocanol 3%. with carbon dioxide usually. Yes, but I have also a question, because we usually, when we do coiling, we usually coil as low as we can. And I saw that you only put the small coil, and we usually coil the whole ovarian vein, and also firstly go really down. And we usually close the uterine vein as well, just to close the enter to the internal iliac vein when we are doing the foam. So we are going down to this varicosities, go to the uterine vein, leave the coil there. We do sclerotherapy, and then do the coiling of the whole ovarian vein. I don't know if it's good, because there are no studies comparing this treatments. And so that's why I wanted to ask you about your opinion about that. What do you think?
Yeah, this is fewer coils than I typically use. Typically, I put in segments of coils. I'll usually put in a tight coil pack every 3 to 4 centimeters from where everything branches at the split into the pelvis. So usually top of the sacrum is where I'll start with coils. And then I'll work my way back all the way to the renal vein and put intermittent coils there. So I may deploy something like 5 or 6 coils throughout that ovarian vein. Mm-hmm. This particular case was a little bit different. For whatever reason, you can see the vein just kind of occluded. Even on that image on the left here, you can see there's thrombosis in the ovarian vein, even after those initial went in. So the whole ovarian vein kind of shut down right away, all on its own, even with this minor occlusion, which is kind of an interesting concept. And maybe feeds the idea as to what is the real source in this patient of their symptoms, and was ovarian vein embolization really the best first choice for this patient? So her pain resolved. She got much better for 4 to 5 months, and then starting 5 months out, she started to have pelvic pain again, and she came back at 9 months, and she was basically back to where she started. Her pain was very severe. So I ultrasounded her again, and you still see this left common iliac vein compression. And the upper right image shows retrograde flow in the internal iliac vein. So now there's a change. Now there's a sump coming from the internal iliac vein. Maybe this was always the problem. Maybe the common iliac vein.
Yeah, what was my question. Do you think it was misdiagnosed at the beginning, or did it change after the embolization? But I don't know how hemodynamically it's possible, what is the way that it's worsened?
Yeah, it's tough to decide. I mean, if that imaging showed antegrade flow in the internal iliac vein, I think it's easy to say, oh, well, this is not significant compression. However, if that changes over time, I don't know if it's just evolution of the disease process and her pelvic sump, her pelvic venous reservoir is now pulling from somewhere else. Just like people get recurrent varicosities from other sources in the lower extremity, they can get recurrent varicosities in the pelvis as well. And here's comparison pre and post ovarian vein embolization of the flow being antegrade versus retrograde. In these two, you do have to look at the scale to make sure you can understand kind of the direction of flow here. But just to point that out, we can see that it's changed. And so now I think we proceed with iliac vein stenting. So I'll kind of move us forward. And here's her left external iliac venogram, and pretty impressive compression by venography. You can see retrograde flow clearly in the internal iliac vein and filling a pelvic reservoir.
Yeah, but the collaterals are quite small. That probably it's not a longer. It may be it changed. Maybe it wasn't misdiagnosed. Maybe it's changed after embolization. I don't know how, but probably it did, because you can see that the collaterals are not that huge, like with the old
obstructions.
Obstruction,
I agree. Yeah. The collaterals are small, although the pelvic reservoir, it seems to be crossing across to the right side and emptying through the right. And here, the second image, you can see placing a stent in this patient, resolving that obstruction. Maybe there's a little less collateral filling after the stent placement, a little less reflux into the pelvic reservoir as well. So seemed to be making her better. At 1 month, her symptoms were completely resolved. Here's some post-stenting ultrasound images. You can see antegrade flow again in the internal iliac vein, which is great to see that that's not retrograde anymore. think that's a really nice picture, better than some of the pre-procedure pictures that I had showed. And she even had 3-year follow-up here. And you can see the stent and the coil, and there's no pelvic varices anymore. And her symptoms continue to be resolved and improved, which is, I think, a nice result. And it begs the question, such a hard patient population to treat, and you have to think about.
Yeah. But do you think that we should sometimes change? Because I usually, even if I see the compression, because you have to remember that in many cases, 33% of general population have an iliac vein compression, and renal vein compression is found in even 70% of patients, and it's usually asymptomatic. Do you think that we should change our thinking? Because we usually start from embolization. Do you think that she shouldn't have done an embolization and that she should have stenting first? Would you change anything in your decision?
I still think it's reasonable to start with ovarian vein embolization as the primary source.
Yeah.
It's so much less invasive. And yes, patency rates of non-thrombotic iliac vein stenting is so high, and patients probably have 98% patency rates with, low rates of thrombosis. I still am hesitant, especially in a young patient population who can be in their 30s or 40s, that you don't want to rush to placing a stent in those patients.
Yeah, I agree with you. I think it should be our take-home message to just, even though that she had a compression, she also had this incompetency in ovarian vein, and we should always think about the less invasive treatment. So embolization first, because it may be helpful.
Absolutely.
So I will start with my case. I will show you the cases, how I manage with the varicose veins of pelvic origin. We have to remember that it's a really huge problem we are dealing with. We are seeing these patients even more often, especially I see this patient more often than patients with chronic pelvic pain. They are varicose veins of pelvic origin, especially vulvar varicose veins, are found in 10% of our population. 22% of pregnant patients had a varicose veins of pelvic origin. They can be related with the C1 changes or small varicosities, but also with a bigger one. 25% of recurrent varicose veins is due to pelvic vein incompetency. So we have to keep it in mind when we see such patient.
Can I ask you a question?
Yeah, the previous one.
Yeah, cross-pelvic collaterals higher up on the abdomen. Do those kind of make you think a little differently when you see those, as opposed to some of the other?
Of course, everything depends when you follow the vein, when the vein is going. In this situation, the vein was going to the clitoral escape point. So on the both sides of the clitoris, you can see the pelvic escape points. And of course, when it's going to the other side, of course, you should also always think about the compression or obstruction. So definitely all the time you have to do proper ultrasonography and check when the vein is going. So in this case, it was because of clitoral escape. But I was really surprised when I saw that in the beginning. I said, oh my God, definitely it will be obstruction. But it wasn't. And I always do transabdominal ultrasonography. So that's a 27-year-old girl, woman, BMI 22, without previous intervention, without previous SVT or DVT. She came because she said that she has a heaviness in the entire leg, daily interfering with the regular activities. But after a longer standing, I was really surprised because she came with a very tight underwear. And I asked, why do you wear so tight underwear? She said, because I have also varicose veins down there. And, we have to always remember that in many cases, the patients are really embarrassed about the varicose veins. I do not think that this varicose vein may be related with the varicose veins on leg. So definitely we should ask the patient about that as well. So after a small, longer standing, she had a bump in her groin. But then she said, and you can see that her labia is a little bit bigger than the previous one. But after a longer standing, her labia majora was really huge. And she said that she has a pain in the labia majora, heaviness in the perineum, which limit the daily activity. That's why she's wearing this tight underwear.
Did she have prior pregnancies as well? Did she have pregnancy? And
yes, she had 3 pregnancies. I will show you this. So she had visible varicose veins on thigh, calf, perineum, and the buttock. So and she was wearing compression underwear all the time. So what information would you ask lady? What is important and what can affect the management?
Yeah,
you
exactly
asked
the
about
question
the
I was
pregnancy.
thinking just now. Yeah, I
Yes.
want to know about pregnancy because frequently these patients present, I've had many of these patients present during pregnancy and their labia is enlarged and they have large varicosities and they need some source of control during the pregnancy. In those, I end up giving them the tight underwear, things like V2 supporters and other things for compression and therapy, because you can't really do sclerotherapy or any sort of treatment during pregnancy, and then monitor them. Surprisingly, many of them will resolve and go away postpartum, but some of them recur or persist like this.
After some years, yes, exactly. So she had 3 pregnancies, and I always ask also, which is very, I think, important question, especially when you're thinking about the treatment, if the patient has the pelvic symptoms, because it definitely may change your point of treatment. So the patient didn't have any pelvic symptoms, no chronic pelvic pain, no dyspareunia, no pain after intercourse. She also didn't have any menstrual cycle disorders, which may be where the patient has a varicose veins in pelvic region. So we also have to remember that among patients presenting with varicose veins due to pelvic vein incompetency, based on the studies, less than 10% have been reported to have pelvic symptoms. Based on Caitlin Gibson studies, even less, so 6% of patients. So what imaging would you do?
You've seen that I prefer ultrasound. I do transabdominal ultrasound on almost all of these patients to assess the pelvic venous.
Okay, I started
joint.
from the leg. So I did the duplex ultrasonography of the lower limb, and she had only anterior accessory saphenous vein incompetency. And then I followed the varicose veins, and because I wanted to find the source where the varicose veins are coming. So I performed the duplex ultrasonography of the pubic area. So there was above this anterior accessory saphenous vein, there was a varicose veins cluster, which was the external pudendal vein. And this external pudendal vein was connected with the clitoral escape points. So I also performed the transperineal duplex ultrasonography because she had also the varicose veins on the buttock and also atypical varicose veins on the internal side of the thigh. So you can see this clitoral escape point, which was incompetent. And she had also intermediate labial. So in between the vulva, there is intermediate labial escape point. And she had also perineal escape point, so it is behind the vulva and in front of the rectum. So she had these 3 pelvic escape points, which were connected with these varicosities. And I can show you how it is. This one is the vulva, and it is this intermediate labial, and you can see that it is connected with this whole varicosities in the labia majora. And the second one, it's in between the vulva and the rectum, and you can see that it is also connected with this varicose veins in the labia majora. And I always, as I told you, I always do transabdominal ultrasonography, but the truth is it needed? Some people may say that it's not, so because it will only show you that there are varicosities around the uterus. Of course, you can check the reflux, you can see if there is a vein crossing the uterus body, which is the significant one for pelvic escape points, but it definitely won't show you, as you told before, it won't show you anything about the ovarian vein, or you can see the end of the ovarian vein when you are doing transvaginal ultrasonography, but you won't see the renal vein and how it's connected with the renal vein. And of course, you won't diagnose the internal iliac vein. But I always do it just to see also if there are other causes of chronic pelvic pain, like cysts, or if there is something gynecologically which may cause the pain. And I also performed transabdominal ultrasonography. So she had almost 8 millimeter ovarian vein with a reflux. So do we need more advanced diagnostic before we decide to treat the patient? What do you think? What treatment would you propose to this patient?
I'm not sure more imaging is needed. I feel confident with ultrasound that I wouldn't necessarily need to get an MRI. I think an MRI could be done if there's ever a question, but this particular patient, clearly there's a very large ovarian vein that's leading to internal and external varicosities. And so the real question is, how are you going to guide, or a hard question next is, how are you going to guide treatment? What's the next step in the treatment of this patient? Do you start from the bottom or do you start from the top? And how do you identify which is more important to treat first?
Yeah, it's, it's my treatment strategy. It's usually like that when I see the patient with the varicose veins of pelvic origin, I see them a lot, 2 or 3 per day. So I do not do coiling as the first treatment option. I always start, if the patient do not have pelvic symptoms, of course. If the patient has the pelvic symptoms, I do pelvic vein treatment. If it is her first, she said that, I have a pain and it's really annoying, I'll do coiling. But if she doesn't have any pain, because I see so many patients with the varicose veins of pelvic origin, I cannot imagine coiling all these patients. It will be, especially that very often they are young and they are asymptomatic. They come for aesthetic reason. They have some varicose veins, which I really don't like, because usually it doesn't look nice, and they are really young patients. So we also have to keep it in mind when we are starting doing this procedure. So of course, when the sclerotherapy, because I usually do sclerotherapy, doesn't work and it doesn't close the varicose veins, I of course do the embolization. But I always start from the beginning, and my experience is that usually they do not need to have embolization for varicose veins of pelvic origin.
Yeah, and I think interestingly, when I treat peripherally in these patients that have mostly vaginal or lower extremity symptoms, they tend not to have a high degree of recurrences. I mean, maybe if they have more pregnancies, with each pregnancy it'll recur, but often if they don't develop pelvic symptoms when you treat from the bottom like this.
Yeah, that's very important also, just to say, because many people ask if you are the patient who do not have symptoms, pelvic symptoms, because the reflux goes further and they have leg symptoms. So if you close the leg varicose veins, will the pains appear in the pelvis? But it doesn't. I don't think it may cause. So I didn't see any patient after treatment of the varicose veins of pelvic origin that the symptoms appeared in pelvis. Have you seen any patients like that?
No, almost none of them have developed symptoms later in the pelvis.
Yeah, exactly. So I performed the sclerotherapy of the clitoral point. You can see that I injected quite deep just to close the whole escape points. Then I performed sclerotherapy of the perineal escape point. You can see also that I usually use quite deep injection, quite deep needle, just to close this varicose veins, because very often when you have the fascia and you inject it just before the fascia, the foam won't go to this pelvic escape point and won't close it, and it may cause recurrences. So here you can see the foam is going, and then this intermediate labial escape point, and you can also see that the foam is closing all these varicose veins. And then external pudendal vein sclerotherapy, and then during the second session, because it was a huge amount of foam which I gave, I did a sclerotherapy of the leg. And here you can see that from clitoris to the rectum, the whole these varicose veins are filled with foam. Here you can see the other projections. So all these escape points, intermediate labial and posterior, perineal posterior point, are full filled with the foam. And here you can see the results. It's almost 2 years after the treatment. The patient feels much more comfortable when she is wearing the stockings. I don't know why, but she decided to wear it. But you can see that the results of such treatment are really good without any recurrences, and the cosmetic effect is also great.
What kind of compression do you put them in?
What kind of compression? Second class.
Yeah, post-procedure.
Post-procedure, yes. But she said that she felt very comfortable when she was using it. I said, if you want, it's okay, but you don't have to. But she said that she likes to wear it. I don't know why, but maybe sometimes it's like that when the patient is wearing the compression for a month or 2 months, she feels much comfortable wearing it. And she said that when she's not wearing the compression, she's think that her body is moving all around and she doesn't feel comfortable with that. Yeah.
Sure.
So is the pelvic vein treatment necessary for varicose veins of pelvic origin? I would like to show you another case. This is a patient, she is a 37-year-old patient without previous intervention, without previous SVT or DVT. After 2 pregnancies, she was completely asymptomatic. She didn't have any pelvic symptoms or any relaxed symptoms. She only came because of aesthetic reasons. So she had a visible varicose veins on thigh, also a perineum. You can see them here. They are not so much well visible, but you can see them quite easily. And also the varicose veins on the buttock. And this is a photo after 3 sessions of pelvic vein embolization. So I will show you her MRI before the treatment. You can see on the first one that she has pelvic escape points and the varicose veins near the uterus. So huge varicosities going on the buttock and on the leg on both sides. And you can see that her ovarian vein on the left side isn't so big. On the right side, it's much bigger. And so we performed embolization because very often when we have, in my observation, when I have varicose veins of pelvic origin, it's because of the branches of the internal iliac vein. That's why we performed the embolization of the both sides, pudendal and obturator vein. And we also checked this ovarian vein on the right side, and of course on the left side as well, but it was okay. So we decided also to do the embolization of the ovarian vein. We combined sclerotherapy with the coils. And after, because we didn't, because of economic reason, we couldn't put so many coils. That's why we decided to divide the treatment into some sessions. So the second session, because nothing has changed with her varicose veins. So 6 weeks after, because of economic reason, we performed another treatment, and we did the venography. And you can see that there are still varicosities, and there are branches of the pudendal vein is still open, and some, and also this obturator vein is also open. So we put another coil, and you can see that it's coiled. Everything is coiled, and we waited. We waited almost 6 months, but nothing has changed. The varicose veins did not appear at all. So we did MRI once more, and we found that left ovarian vein was bigger than it was at the beginning, and it was incompetent. So during the third embolization, the third session, we performed the embolization of this ovarian vein, and we checked everything. Everything was coiled. So young woman with the many coils, unfortunately, but nothing has changed. The varicose veins were still there. And it was her main problem. She didn't have any pelvic symptoms. So I decided to puncture this pelvic escape point and to check where the foam is going. And as you can see, I did a venography from this pelvic escape point, and you can see that the foam is going directly to the place where the coil is. So the coil do not close the varicose veins at all. So I decided to perform sclerotherapy through this injection. And she also had this huge pelvic escape points on the other side. So I also injected the other side and did a venography on the other side. And you can also see that the contrast is going to the place where there are a lot of coils, which didn't close the varicose veins at all. So I performed sclerotherapy of this pelvic escape point, and then of course I performed sclerotherapy of this leg varicosities. And it is the 2 months after the treatment, you can see really brilliant results. So definitely I think that this coiling in patients who are not symptomatic is not a good one. She is 27-year-old with, at least 20 coils in her body. So in conclusion, why do I choose bottom-up treatment? The top-down treatment didn't prove to give good results. Very often multiple embolization sessions are required, and we have to remember about the radiation exposure, contrast use, agent use, so about your kidneys, and extended treatment time. You can see that when I did the sclerotherapy, after 2 months, you had the brilliant results. And the whole treatment before that, it was almost a year. and nothing has changed. And these patients are often young, completely asymptomatic, and come for aesthetic reasons. And the results of bottom-up treatment are really good. It's definitely less invasive, less harmful, and can be repeated if required. And then definitely it's cost-effective. So, thank you.
Thanks so much. I mean, this was amazing. These cases are always so challenging for us to manage and treat and identify the optimal source and identify the best plan of action. And we're learning a lot. There's a lot of research happening. I think, I encourage everybody in the audience to listen in. We have the UIP meeting coming up in September. We're going to have several sessions on this topic at that meeting. And I think we're going to expand this conversation and discussion in a lot of ways at that meeting as well as others.
Yeah, definitely. It was really great to have an opportunity to discuss with you. I always like it. It's really amazing.